Now, what are your thoughts on the limited duration therapy based on some of the emerging MRD testing?
Sure, and MRD testing is certainly a valuable tool especially in diseases where we use that heavy hitter chemotherapy, like an ALL, for example, where we have definitive data that will tell us that negativity in MRD corresponds to longer response rates and better outcomes. CLL MRD is a little bit more unique, and it has promise in outcome prediction for sure. There's some data dating back to about 2012, a reanalysis of CLL8, which told us that obtaining a very low MRD or negative MRD, which they measured as less than 1 in 10,000, did correspond to significantly increased progression-free survival times compared to medium or high levels of MRD, which was about 2 years per category in improvement. And overall survival data also trended in the right direction there too. However, the question really arises, now we get into the more current setting of using these oral agents, especially single agent BTK inhibition, maybe single agent BTK with a CD20 inhibitor combined with it, is that we're not really going to expect our patients to achieve an MRD in this case. The way that drugs work, they kind of suppress the disease and keep them in a long-term, partial response, but that could be good enough for long-term disease control, very high progression-free survival, very high overall survival, and toxicity data that's usually very acceptable for all of these oral agents. So even though we're not seeing those deep remissions with MRD negativity, undetectable MRD, we certainly are still seeing a large benefit in using these agents, without that. It does become a little bit more interesting as we get to that fixed duration, such as venetoclax and obinutuzumab. There's some data now with venetoclax plus ibrutinib to get those more deep remissions, including MRD negativity, and then we potentially see these patients stop the drug. So they're not committing to that lifelong therapy of taking a pill or several pills every day, and lifelong toxicities that may be associated with that, things like that. The question we really need answered at this time is if these MRD negativities resulting in withholding or stopping the agent will lead to long-term response and how long that response will be. Another question that we'll need to see the literature answer is if and when the disease were to come back, would we re-challenge with the same agent that got us to that MRD in the first place? Or is it like other diseases where we tend to shift therapies after a certain treatment failure? So, the goals of therapy based on MRD, really, one of the benefits is certainly reducing the time on therapy for a patient. I have many patients who will be on maybe 1 or 2 other drugs. We know that CLL is not very discriminatory with how healthy the patients are when they get it. So they'll ask me the first question, how fast can I get off this drug? I don't want to take this drug forever. I want to be done in 3 months, 6 months, 12 months, as soon as possible. And I have other patients who might have, 10 to 12, 15 to 20 other medications, and adding 1 more pill is really not a big deal to them. They're going to treat this like a chronic disease. And the data tells us they can take ibrutinib for a really long time and probably do really well. So again, it gets into more of that patient-specific treatment plan with if we're going to have a goal for an aggressive MRD negativity, treatment, or if we're going to keep this as a chronic disease and possibly use monotherapy and for long-term disease control. And what are your thoughts on that?
No, I definitely agree. I think it's definitely the data, especially as you mentioned with venetoclax in the relapse refractory setting as well from the Murano trial, definitely looks promising, but you're right, it's very patient specific in terms of that being a goal, but also if that patient's willing to be on therapy for a long period of time. So it might be more of a win for some patients if this sort of pans out as an approach to stopping therapy. So I think we'll definitely see as the data matures and perhaps look to the chronic myeloid leukemia, the CML literature that's evolving and recommendations in the NCCN guidelines on therapy discontinuation for those patients, is that I would imagine some of those sort of general principles might also look the same in terms of when to stop and potentially when to consider resuming. So it'll be interesting to see as the data evolves. I definitely agree.